So this slide is an overview of image segmentation as a machine learning task, and the basic goal is to assign a particular class to every single pixel in an input image. The input image in this example is just a dining table with some chairs, and there are two types of segmentation tasks. One is semantic segmentation, where each pixel gets assigned a particular kind of object. For example, all of the chairs get the same chair label, and then instance segmentation, which is a slightly different task where each individual object has its own label. So in that case, the different chairs would each be distinguished from each other. You can go to the next one.
Go ahead.
Oh, go ahead.
No, go.
So one important consideration for this project is that the level of detail desired in the final model has to be defined at the beginning when the data set is prepared. And that's mainly because if later on people would want a more general category, it's easier to group together finer labels than to attempt to later obtain finer labels from coarser ones. This figure shows the original image where there's a couple people at a table, and one option for assigning labels would be to assign labels to whole objects, for example, the table and the people. Alternatively, for slightly more detail, coarse object parts such as faces or a cup could be segmented. And then if a very high level of detail was desired in the final segmentation, then you would need a ground truth that had very fine annotations, for example, different parts of faces like eyes and nose and so on. So there are several different examples of segmentation applied in a surgical context. This paper was attempting to segment different surgical instruments from laparoscopic videos. And I think maybe the next slide has the segmentation masks. I'm not sure. Yes, there they are. So the outputs here of the model are one if the pixel is part of the surgical instrument and 0 otherwise, which produces these black and white plots that have the silhouette of the surgical instrument.
Perfect. Okay, so I'll just conclude this, and then I'll hand it to Pat. So so the bottom line is that with the segmentation, with the deep learning, obviously, we're trying to identify a taxonomy of terms and types of tissue that we wish to segment, and then once we have that, and once we have labeled segmentation, then we can train a deep learning algorithms to do that automatically. So Pat, are you still there?
Oh yeah, I'm there. Perfect.
All right,
so jumping into our assignment essentially for our group, we were tasked to essentially start working on the work of labeling for the purpose of video segmentation. So if you think about the basic concept, focusing on anatomy, tissue characteristics, and surgical tools, it's that they're going to be essentially the actors within the surgical footage. So you have to think about the semantic background, the general anatomy, specific anatomy, and then go over the type of surgical tools that are conducting specific actions on the tissues. Next slide, please.
Okay. Okay. Is that good? Can you see it, Pat?
Okay, yeah. So the anatomy part was probably the simplest one. So we obviously need to define the intra-abdominal anatomy. So the way we worked around it is we broke it down between the basic anatomic region, for example, the upper abdomen, the lower abdomen, the pelvis, or the retroperineum, and the groin. And then we went into a subdivision or sub-classification for general anatomy. And we tried to follow the same framework to really try to standardize it across the different regions. So specifically looking at the veins, arteries, the nerves, fat tissue, organs, muscle, fascia, sheaths, ligaments, and lymphatic and ducts in each one of those basic anatomic regions. And then, of course, then you have to go into the specific anatomy. So then we go into the specifics of the particular organ in a particular region. So we'll show you what that looks like when we try to label all that anatomy and put it together. Next slide. Okay, so this is just the concept. We're essentially trying to think about labeling all these organs and then think about the instruments as performing actions on the tissue. Next slide. I'm sorry, there's a delay, right? It's a little slow.
Yeah, it's
okay.
Here we go.
Perfect. Yeah. So the key thing would be then ultimately when we move to tissue characteristics, and this was definitely the most challenging but the most important probably of the task is to try to define what constitutes normal tissues and finding way to label what normal anatomy looks like. So not just normal, but the tissue characteristics of the anatomy in question, and then being able to contrast it with a different set of labels to define different states of alteration. So obviously you think about a gallbladder, being able to describe a normal appearing gallbladder that the machine would be able to recognize, and then be able to tell whether or not it's in a state of inflammation, whether or not it's thickened, enlarged, or infiltrated with fat, or with fat deposit on it. So this is really what the task at hand was, to be better able to define the tissue characteristics in question. Next slide. Okay, so this is really the labeling that Oz wanted us to follow. So again, the instrumentation, so you think of all the surgical tools like grasper, scissors, and dissector, or the subject in this framework, and then they're performing an action, and we'll have to be able to define that action based on the type of instrumentation being used and how the tissue gets deformed. But ultimately, the target is the anatomy in question that we talked about. So it was really important to be able to assign very specific labels and come up with a consensus on the labeling for all different structures and these different subjects, action and object. So this is the last slide for the PowerPoint. Larry, can you go to the Excel sheet, and we'll show you what the group has been working on trying to really define those labels. And this is still very, very much in a draft form, but you'll see a lot of work has gone into this to try to really encompass every possible permutation. So anatomy, we really try to describe every organ, every structure that we would encounter in the upper and lower abdomen, as well as retroperitoneum and the groin. So thinking about hernia surgery, for example. And you see how we broke it down between region anatomy and specific anatomy. And we follow the same framework. And it's pretty comprehensive list. Our surgeons have been very helpful to fill in the gap of specific anatomy. And you see some areas, some regions do include bony structures, and some ligaments, and some really specific recognizable structures, which you think about will be relatively easy to label. And will be very important for the machine to obviously learn to recognize. So that's probably the most straightforward task, is to really all agree on all the structures that we would expect the machine to identify in each different anatomical region. Larry, if you can click on tissue characteristics. And this one is definitely an evolution. Even today, I got a lot of feedback from, I think Swaroop is on the phone. Some really helpful feedback from our engineers, I think, was really valuable, because, it's very multidimensional when you think of tissue characteristics. And I have added, exponentially a number of other characteristics, which I really didn't really think about as much personally, but are really critical. So the way Swaroop actually suggested thinking about characteristics is not just state, as I had started with, or consistency and density and orientation, but also thinking about it in terms of shape. And also adding the sublayer of coloring and viscosity can be very relevant. Movement, that's the one that I hadn't thought about until today, that he mentioned is true, whether or not the tissue is static or pulsing or moving. You think about peristalsis, and you think about the ureter vermiculating, for example. So being able to label movement of the tissue, not as a result of the action, but just in its natural state, will be very important for the machine to recognize. And then other dimensions, surface, so the actual anatomy of the characteristic of the surface of the tissue. Continuity, I thought, was a really interesting one. So discontinuous versus continuous, and we'll go into the specifics, but also size. And we talked about margin, not just the organ, for example, itself, but its edges could be relevant also to label. So I included that as well. So if you think about tissue state, this is probably the most, logical one to think about, whether you're dealing with blood, liquid type of tissue, or then the consistency is more on the state, solid versus rigid or viscous. And you can go through this whole list. I mean, it's pretty straightforward, but we try to essentially label the states that you would imagine different tissues to be in both normal physiological states as well as pathological states. Then we try to break it down more in terms of consistency and density, especially in response to instrumentation. So trying to grab tissue and encountering resistance, for example, which would tell us to label it as firm or fibrotic or thicker tissue that you would have in a normal situation. But also, as we talked about inflammation, but this, there's different degrees of inflammation. So we also added things like edematous, spongy, soft, gelatinous. You can see also characteristics like sticky, the tissues being adherent or not separating easily, or tissues being fused. So the same type of labels that kind of represent the same type of consistency of the tissues when they're being manipulated. Likewise, tissues being elastic, redundant, stretched, and loose. So you can see for what, we struggle, or not really struggle, but we'll have situations where you have 3 or 4 adjectives that are trying to represent the state of the tissue. And I think it will be important to have a consensus on, particular, possibly just one term with other possibilities. But, I think the struggle will be, do we define one single term to reflect all these potential states or these potential tissue characteristics? And that'll be open for discussion, what we do with these different options that kind of represent the same state. Then moving on, I don't want to spend too much time. It's pretty self-explanatory, but you can see also the other category is that it's very important for the machine to recognize tissue orientation, not just in relationship to its surroundings, but also in relationship to itself, is an important one. And then tissue shape. We talked about color, also characterizing it based on normal color and pathological coloring. Tissue continuity, I just mentioned. Tissue movement also. So as I said, tissue at passively moving and peristalsing and pulsing like a vessel versus being static. And then finally, if you can move to the right, I think there was one more. We talked about tissue edges or margins of organs, for example, and describing them as well potentially. So you can see it can get pretty granular, but I think that was exactly what Oz wanted us to do, and I hope that's sort of what you had in mind, to be able to cover all possibilities for tissue characteristics. And then we moved on to the next section, which was instrumentation. And that one was a bit more straightforward. Again, we tried to define sort of the general type of instruments, the different, based on their different actions. So focusing on cutting, dissecting, graspers, staplers, the cameras, suturing devices, retractors, suction, and then you can obviously get much more granular with specific instrumentation. And under each of those categories, we can get really specific in terms of the type of device that we all know. We know, and we can codify those instruments very easily. I did not include brands because I don't really think it's relevant to have, Olympus versus a ligature versus Ethicon device. I think is irrelevant right now. I think it's more important what the anticipated action of the device will be, and that's something we can discuss. The granularity of each specific type of instruments. More important will be the anticipated, shape and design of the instrument. So the machine will be able to probably analyze it or anticipate possibly its action. But I think it's important to also define it by the angle of the tips of the instruments, whether they're pointy or blunt, and then whether the shaft is flexible. There's reticulation or flexibility to the instrument. And then obviously attributes like whether the instrument has teeth to it versus having smooth tips will be very important. The final category is more the other types of instrumentation that you would expect the image to also include. So some of the additional devices that you can see on the screen during these procedures, and that's sort of like another category we can focus on later as needed. So I'm going to open it. I don't know if Larry wanted to add more to this before we open it to the larger group. Larry?
No, that was great, Pat. So we can open it up. So I think we should just go ahead, Pat.
Yeah.
Pat and Larry, thanks so much for this great presentation, and that's exactly the point where we want to go. This is the last presentation of the 4 groups, and we started software last week and have tempos and actions and tests this week, just preceding you guys. Clearly, you're just like labeling the actors on this whole scheme of video annotation. And as far as like one of the themes that was being discussed today was like, what is the level of granularity that you want to do as you are like, annotating the tasks, for example, right? But at the same, you can translate to the tissue. What's the level of granularity you want to do that? Or for the tools what Pat just mentioned, let's say you have a Maryland dissector or a pointy dissector. I mean, aren't they all dissectors? The overall like suggestion is that we should at least have a framework that's scalable to the different levels of granularity, but maintain the hierarchy so we can actually use the current annotations to the future. And I want to hear like Pat and Larry's opinion about this when you're going to be applying this to tissues and tools as well.
Yeah. So that is a key question. What I would say is the machine learning should be able to accommodate multiple ways of doing the segment labeling, and the amount of data that depending upon how it's done, the amount of data that will be needed to learn will be different depending. So the idea is that surgeons may use, let's say, fairly general terminology for segment, and then visually there could be a great deal of heterogeneity for that same label of segmentation. And if that's true, in other words, if that's what people choose to do, then the machine should be able to learn it, but it will require enough data to capture that heterogeneity for that particular type of segment class. On the other hand, if the surgeons choose to be more specific, such that there are perhaps many more label types for the segments, then the amount of data that one would need for each type would be reduced. But then, of course, you have a larger taxonomy. So in the end, it might be comparable from the standpoint of how much data we need. But in any case, what I would say is the AI and machine learning can accommodate what is clinically useful, and so I think that really is the question. So how would the surgeons like to define the various segments?
Great, yeah. The other
Is
thing
Farouk on the phone?
Yeah.
I just wanted to get also his.
Go on, Pat. Yeah.
Can you? I think you muted, Soroup. You wanna join in?
Yep. Thank you. The granular is thinking of it as hierarchy.
Oh, we can't hear you. Can you call in from your phone instead? I think you're talking from your computer, and we can barely hear you.
Hi, this is Anand Malpani from Hopkins. I had 2 thoughts. One was I really liked the granularity and the different types of attributes for the tissues, but I was wondering, of those, as conversions, how many of those can be assigned by doing an offline viewing versus being in the operating room?
How many can be assigned offline?
Yeah, by just looking at the 2D video, because I'm an engineer, so I don't know like if all of those are obvious to me, but maybe they are to a clinician.
And that's an excellent question. I think it's at least to a surgeon, it's everything is in contrast to normal, right? So I mean that's another question. It's for example, we have these orientation, and you talked about something being twisted or herniated, and Swarup, you mentioned very rightly so. It's like, well, it's only in relationship to another organ, so that may not be even obvious to the machine unless you have the machine understand what normal anatomy looks like with variance, and then you show an area, the same anatomy, but where things are completely twisted around an adhesion, for example, and there's dilation. And so it will be teaching in relationship to a framework, to a baseline. I don't know if you can do that. So it's like going back and forth, normal, not normal, normal, not normal, not normal. And eventually the machine should be able to recognize the segment that's not normal because it is labeled as twisted or torsed. I don't know if is it doable?
Pat, I mean, before Pat, before you comment on that, I just want to add something to what Pat just said. It's exactly like we learn since we're medical students and interns, we learn what's normal. And then we start seeing alterations and they say, what is that? A lot of the times, if you're like a medical student and intern, say, I don't know what it is, but I know that's not normal. And then you start understanding what does non-normal mean, to start differentiating them and come up with like different diagnoses. And might be the framework we want to go with this.
Yeah, so just on that point, given the fact that not normal, there might be quite a range of not normal. So just like you said, Oz, it might be good to in the context of machine learning, to focus on normal, at least to define the segmentation in terms of normal. And then the machine should be able to identify things that it does not recognize as normal. In other words, exactly what is making it not normal will not be evident. But the idea would be that the machine should do hopefully exactly what you said, Oz. And then, ideally, when the machine recognizes something as not normal, and then let's say a surgeon could say, yes, it is not normal, and it is this. In other words, to say what it is. Then, with enough examples of that sort, the machine should be able to learn those particular types of not normal.
I want to point out two things that I think I've learned from this exercise and this conversation. One is abstraction and hierarchical thinking. Those are necessary. And second, the second is what I think Pat said just now, which is being able to think it in a way that helps us systematically build what is normal, build the idea of what is normal. So thinking of it as like Legos. Am I building a car? But I'm building a car with a bunch of pieces, and those pieces are the building blocks. So if we think about it hierarchically and go granular, and also abstract it out to a certain level, not too far out, but to a certain level, and those will become building blocks for what we want to build as normal. For example, we are looking at a two-dimensional picture, which is what Anand asked. That is great, but I think if we as a human, if we saw that, we're able to build a picture of what's in 3D, not because we can see the 3D in the image, but because we already have a 3D map in our mind. And that is exactly how engineers think about models. You can give an image to a model, and the model will not see anything beyond the two-dimensional picture. But if it has a map, then it can reason. But building the map, but the way we can help it build the map is by giving it data, structuring the data with hierarchy or granularity and abstraction.
There's a very great point you just made, and goes along with the same line of thoughts that we have within actions and tasks and temporals and software as well. The fact that we should have this framework of how we're going to be annotating either the temporal or the visual models, but they should fall in some hierarchy where we can either expand up or down, one less granular and less granular, that eventually each one of them going to fall on a larger bucket, and those can be exported to different portions of the procedure, to the point that you can add any component of, let's say, inflammation to any tissue, or make any tissue part of any portion of the procedure, make any action that could occur to any tissue, and you just kind of like mix and match, even like if somehow sounds like illogical, because you wouldn't like to do a gallbladder transplantation, but if you could, then you put everything into the context of the temporal modalities, then you build procedures. It's exactly like almost like we learn, in medicine. Of course, we don't do out of the ordinary things because we're not allowed to, and we should not be doing that. But if you could extrapolate this to machine learning examples, by doing that, what you just said, that's like exactly what the foundations for a universal annotation for the years to come.
I just have like a quick idea, like looking at these like presentations. I think that, you guys did a fantastic work. I mean, it seems clear to me that annotating anatomical parts is far more difficult than temporal and actions and tasks. So perhaps would it make sense to create a different level of granularity when it comes down to annotating tissue characteristics, especially in anatomy, that serve different purposes in computer vision, so that different annotators that, of course, have a different cost. So, for example, like a junior surgeon would be able to see temporal sequences and actions and tasks, but would not be necessarily able to annotate accurately all the anatomical features of a video. Would it make sense to create different layers so that those different layers and those different modalities, more expert annotators versus less expert annotators, would serve different purposes in computer vision?
Yeah, I think I agree.
So Larry, go. Whoever's commenting, go for it, because I want to have a comment as well.
Sorry. Yeah. This is Anand, and as I was mentioning in the tasks and actions group also, like depending on the hierarchy and the granularity, there can be different levels of expertise in annotators who can do the job more, I guess, effectively or efficiently, and we can use the annotation resources in a wise manner so that we don't end up losing time from a highly experienced surgeon in annotating things which would be more trivially done by, let's say, a medical student or even like a layperson.
Yeah, so if I just complement that comment, like Filippo, on the software group's presentation, we discussed exactly that, the ability to allow different level of expertise to annotate different level of like complexity within the video. And the thing is like, and it's important this to be absolutely like modular and independent of the others, but at the same time allow to correlate with the others. Because let's say if there's a tons of annotation about gallbladder, inflamed and inflamed, all the thing about inflammation, I would like to transfer that to a appendix or a Crohn's disease or something. And if I have never seen an inflamed appendix, but I've seen 100 inflamed gallbladders, I would like the machine to look at this appendix and say, you know what? It is an appendix, but it looks like it is as inflamed as a gallbladder. It kind of starts implying, exactly like when we learn medicine and when you see something and say, I never seen a Crohn's disease patient, but this small bowel looks kind of like a bad gallbladder or a bad appendix I've seen before. That's the idea.
Hi, Oz. I think you might be right that the machine will give a high probability, but it's not sure. Give a machine an image that he has never seen. In this case, it has never seen, so it is risky to say the machine will tell something. Yeah, it's highly likely a gallbladder is with inflammation or something. Yeah.
No, you Tom, thanks for your comment. But this is we're talking 2020 right now, right? But we're trying to build the grounds for 2030 and above, right? So hopefully in the future, by building what you're building right now, that would allow machines in the near future to be able to make those types of like assertions. That's my personal.
Yeah, sure.
And the other question I have, because I mean, this is something that also I'm thinking, and I appreciate the complexity of seeing, something that's inflamed, and and there can be different degrees of inflammation, and it can be interpreted differently by a novice versus an expert. But I was wondering, is there any way you can also have an algorithm with a machine where they take not just one dimension into account, or there's multiple dimensions, meaning inflammation alone counts for one. And this is me thinking just outside the box. I'm not an expert in this at all. But the inflammation plus, something is stuck to the gallbladder, which normally the gallbladder is not stuck to anything, say a piece of omentum. And so you have that dimension of tissue characteristic of inflamed, check. And then you have edema, check. And that's something that can be taught. And then 3 is, and there's something stuck to it or adherent to it that suggests inflammation. And so the machine would infer, based on those 3 things, the likelihood that the gallbladder is inflamed, that disease cholecystitis, is 99%, as opposed to there's only one of those 3 characteristics that they've been trained in that is positive. Can you get to that level of hierarchy, not so much, but of granularity using multiple labels to achieve a higher rate of accuracy? Can we do that too?
Yes, Pat. I was just typing exactly the same thoughts in the spreadsheet just before you were talking, and I think for the last part of your question, the accuracy of the machine is one thing, but the machine has more value to add than beyond accuracy, which is understanding. And the question that I was writing in the spreadsheet is, how do we think about this hierarchy? And just in a way that you explained, inflammation of a tissue does not necessarily have to be, it won't be labeled with the same set of lower order terms. For example, it need not be adherent in all scenarios for it to be inflamed, for us to call it inflamed. So, but some of them are cardinal. Some of the lower order terms are cardinal for higher order terms like inflammation. When I was looking at the tissue characteristics, and what I figured is we now need a set of higher order terms to add to the vocabulary, and then think about cardinality of the lower order terms. I was just writing it, and then I heard you talk about it.
Yeah. It
also seems.
No, go on. Sorry.
It also seems like from the spreadsheet that perhaps there is a distinction between labels that are intended for segmentation, i.e. you would trace an outline around that particular label, versus labels that are more like tags. So perhaps inflammation is a tag, not necessarily a certain area that is traced. Or maybe it is an area that is traced, but that seems like something that could be useful to define, is whether all of those labels correspond to something that needs an outline, or if some of them can be thought of as tags on top of a structure that's been outlined.
That's a nice
Yeah, so that's a really good point. Yeah, that's a really good point, Rachel. And so if we think back to the slides at the very beginning, where we were showing the segmentation of chairs and whatnot. So that that I think will be something that the surgeons will need to think about. Like, there'll be just exactly like what Rachel said. There'll be some which will be kind of a meta tag of the image itself, and then there'll be other, such as inflammation perhaps, and then there'll be other things where there will be detailed segmentation. In other words, circumscribing certain regions. And then, the other thing is that by combining perhaps those meta tags with the segmentation, then the hope would be that there should be a capacity for the machine to do a higher level, a hierarchical form of reasoning that was talked about earlier.
And it would even be possible to have tags of specific regions. So there could be tags on the whole image, and then there could also be tags on, say, a specific organ, like the gallbladder gets tagged with inflamed or something.
Yes. Mm-hmm. Yeah, and so Rachel, so this is exactly what I think that will be the ideal thing for us to accomplish. Is like, what are the things that could universally happen to different organs? What are the things that are only specific? And then also, even as an example, some organs, you can move them around and you can have a different background. For example, with small intestine, I can actually move it up to the upper abdomen, to the lower abdomen. I can do different things. And that's why I wish eventually we're going to get there, of course, that the machine could actually put all those little things together. The organ that we're working with, the tools that are manipulating the organ, and the background that's seeing it, and put all the semantics and perhaps, guess where we are state-wise and make the prediction of what's going to happen next.
Hey, Oz, I just wanted to jump in and drop in a couple of comments before I have to head out.
Yes, please.
This is Anand again. One thing was from the instruments spreadsheet, I thought something that the accidents group mentioned was associating which instrument is doing what, and so it would be good to annotate in addition to the instrument categories, like if it's an assisting instrument or delivery instrument versus one of the main instruments being used to do the current step. And the other was with regards to the spatial tagging component, which was also discussed as a feature to say if there's a temporal event being labeled, can we tie it to a particular spatial actor in the scene? And so these would be like quite synergistic discussions that happened earlier. Yeah.
No, I mean, it's a great comment. I agree with you. As far as what I think, as far as, for example, labeling like instrument, right instrument, a hand, left instrument, or just like a main instrument. I personally think that it's not as necessary for the beginning level granularity you want to have for the annotation, but eventually, yes. The thing is, like, sometimes in different parts of the world, and even here in the US, when you're doing the surgery, it could be do surgery on the right side of the patient, left side, in French position, and you don't know exactly which one is actually the surgeon, the other is not the surgeon. Of course, a lot of the times the instrument that's doing the majority of the work is the main instrument. So maybe calling main and auxiliary instrumentations might be like an option for that.
I wanted to hear some thoughts on the anatomy because in my mind, what I'm seeing in the spreadsheet, I'm not able to actually make the connection between whether that is the task that is the problem that we actually want to solve. I just wondered if anybody had thoughts on the anatomy part of what we are seeing.
Could you repeat the question one more time?
Yeah, I couldn't understand either.
What we saw on the anatomy spreadsheet, I'm trying to understand whether that is the question that we are trying to answer. For example, for each of the regions in the abdomen, we have veins, arteries, nerves, fat, tissue, organ, muscle, and fascia, and lymphatics and ducts, and so on. And we are able to list out a number of items for each of them. So we are able to list out a bunch of veins, for example. Is that how? I'm trying to understand what question this is solving.
I mean, if I understood the task, Oz, it was essentially to be able to label every structure, intra-abdominal structure, to essentially know anatomy standpoint or from a procedural standpoint. You know, if you do a gallbladder, what organs are going to be relevant to your actions? And, you know, if we put all these procedures together and all the anatomy that we encounter during any type of these procedures in the abdomen, these are the essential anatomy. These are the organs, these are the structures that we're going to be encountering and that we have to be cognizant of.
That is correct. It's like the best analogy you can make for our surgeons. Let's say we're labeling the vehicles that can actually drive over roads, and then those are cars. You can see cars in the highways in a city, on the country roads. You know, those are trucks. Those are things. And again, what we're trying to build here, if you're thinking about that you're building like a movie, they're going to start and going to end. Those what Pat and Larry put together are the actors that's going to be playing on this movie, and we just need to label them, know who they are, because when we want to try to compare data, I want somebody in China to label gallbladder exactly somebody labels in Canada or in South Africa. Not in somebody going to talk about inflammation similar in those places. That the question we ask is like let's standardize the actors within the peritoneal cavity to move forward with like combinable data sets.
Do we want to answer do we want to be able to answer the following question? If there is a vein visible in an image, do we want to be able to say, look, I have annotations on tissue characteristics, and for this region, these are the tissue characteristics, and this looks, based on these tissue characteristics, this looks like a vein. Do we want to be able to say that?
I would say ideally, yes. And not just that, but imagine, like I say, you see a vein, and then you see the background behind that vein. You should be able to imply which type of vein is that.
So Oz had a picture that from the PowerPoint where you saw that the IMV and the duodenum.
Yeah, can you bring that picture?
Yeah, Larry, if you go to the PowerPoint, like this is the kind of picture that when we teach our residents or even our medical students, you know, you pause and you look at this picture, you should know exactly what that structure is. It's one of those classic hallmark anatomy when you're doing.
Let me see if I can share mine.
When you're doing colon, yeah. When you're doing colon cancer surgery, especially left-sided colon cancer surgery, this is one of the key steps of the operation is to identify
can you guys,
the IMV.
Can you guys see my screen?
Not yet. So there's certain, just like the triangle of Collot for the gallbladder, you know, every procedure has steps, and so there's certain anatomic features that you need to be able to recognize immediately. If it's just one of the, even regardless of the tissue characteristic, you should know this is the IMV, the aspects of the IMV, and then the next step should be the machine should also know. We anticipate that the next step will be, you know, you'll be elevating the IMV and getting the plane between the IMV and the retrocranium open and dissected. That's just one of those surgical hallmarks.
No, I mean, you got right on point that because the thing is, like, we should not be training every single vein. Let's say, for example, you see in our body, oh, that's a vein called this and this. By seeing the anatomic, by knowing the anatomic region, by seeing the background semantics, then yes, you extrapolate to assume that that's what you're seeing. You can see, like, when you're doing a hernia surgery with the femorals and the iliacs and the epigastrics. When you're doing gastric surgery, the short gastrics, they're all going to look the same. It's just depending what's the relationship with the tissue that you are seeing and the regional anatomy. Has the image projected yet? No.
We're on the slide on the surgical instruments. So that's like the slide. This is Rachel's slide right before going into your slides.
Okay. Just because I cannot show mine, but yes, exactly. Yeah. So it would be the one that, and also if you look at, let's look at the very last slide, the one that's with the semantic background right there. That there is a.
I'm trying to get it up. I'm trying to get it up.
Larry. Yeah.
Guys. Yeah.
Okay.
Anyway, keep going. I'm trying to get it up.
Yeah, no, so I'm just saying, for example, let's say the very last slide, right? It shows an image. If I show to many surgeons who have gone through already, have gone through a surgical training, they're gonna tell me this is very likely to be a inguinal hernia repair, just with a single picture, because they see that that's the peritoneal view of a inguinal area. They see that there is a needle holder holding a suture. So here I can even tell about the action that's being performed. And then I can even assume the task is being, asked to do. And even which portion of the operation. So that's why it's so important. And if I train the machine, let's say, just to see, like doing this inguinal-raphy, that closing the defect of the hernia, imagine then when I can actually extrapolate, move this to the upper abdomen, when I'm doing another type of hernia that's closed the hiatus for reflux, and I don't need to be training the machine that's called suturing again. So that's the idea of breaking this down into building blocks of Lego that, like we discussed today with the actions and tasks, can we transfer the actions and the tasks to different parts of the procedure? Yes. Also, could it transfer the actors we have in the abdomen to the different types of procedure? And the answer should be the same. And what Pat said on this slide, I think was the one that just after when Rachel talks about that you see a structure that looks like a vein going under a structure that looks like an intestine with the background of fats. Then you just say this is the inferior mesenteric vein. So
can you guys see? I'm trying to project. I think I'm projecting now.
Let me see here. Go forward. One more. This one. Go back. It's the one that has a lot of fat on it. There you go. Pat, do you want to go ahead and just describe what you're just saying? Pat?
I was muted, sorry.
No, it's not that, yeah.
This is sort of like, this is one of those images that when we talk about one of the typical steps of a colectomy, a left colectomy, this is one of the steps that needs to be done. And so this is, I would expect every single resident who is learning left colectomy to know, to recognize. If I show them this image without any annotation, they should be able to recognize not only exactly what the structures are on this field, but also, you know, what the next steps should be and what the procedure is. I mean, we have, you know, typical anatomical landmark, you know, moments, just like for gallbladder when you're, you know, you have the triangle of Callot exposed. This is one of those typical steps in a left colectomy that you would know corresponds to that particular step.
This was a very interesting conversation. So what it makes me think is the following. If I did not have the context that this is a left colectomy, let's say I am a first-year resident, I just walk into the operating room, I see the belly open, you show me this. I don't know what you're doing. My first year. Yeah, so then I would say that seems like either it looks a little bluish, so that must be a vein. There's a lot of fat. And I know I'm in the belly, so I'm somewhere around somewhere the peritoneum is somewhere around me, and I see a couple of instruments. One of them is a grasper, the other is something. There's something on the lower border of there's some tissue on the lower border. I can't say what it is. So this is what I was thinking, and this ambiguity is what we will be left with if we focus a lot on the tissue characteristics with granularity.
Yeah.
At the same time, so I think the one of our tasks when we get together with other people, who are working or thinking a lot about the other tasks, is how do we think about this ambiguity? So if you tell me it's a very left colectomy, then if you give me the context that it's a left colectomy and we are on the left side of the or we're on in this part of the abdomen, I might be able to make a guess. For example, I was in a gastrectomy case and we were seeing a few vessels. My chief asked me, "What are these vessels?" I was able to read them off because I had the context of what was going on and how we got there. So this ambiguity is something that we should talk about as a group when we come to talk to people who are thinking of other activities.
So just like two parentheses there. One is like, I think we should start thinking about this as of tonight, not wait until get to Houston. And then I think people who are interested in discussing this with tissues and actions and tasks should get together and be in context prior to it. But the other thing I'm going to say this is, okay, the context here is, for example, if Pat and I just said, if we show this to our residents, it's like this. If we're showing this to our resident, means this patient's in the operating room and the instruments are inside the abdomen. Therefore, what are we doing, right? There's a context right there. And that's the thing, the pretext I think we should have to take as we move forward of this is that every single surgical image we're showing here right now, there is a patient undergoing surgery with a goal. And therefore, if you see those cues, visual cues such as this, we should preclude that. It's very likely to be this type of operation. Like this image that we're just showing right now is a very classic one for colectomies. We can show the critical view of safety for lap choles. We can show, the dissection of the inguinal floor for hernias. And you can give many more other examples, the hiatus. So some of them are very, very classic. Is unmistakable. But the reason I would show this picture would be that if I only show the bowel with anything else, the only thing I can say is a bowel. If I only show the vein without anything else, I can only say it's a vein. If I only show the background, that's fat. But when I put them together, I come to the conclusion. So it'd be nice to be able to, when you talk about the granularity of like labeling things, is to scale to a point that I can label universal structures, fat, vessels, gut, that can actually translate to others. So every time you're labeling them, the machine is learning overall.
Yeah, so,
It's also totally
that's really, sorry, Pat, that's a really important concept, Oz, that even if there are generalizable types of segments, generalizable across, organ type or surgery type, those could be really important for, what we call transfer learning. So, in other words, the learning about one surgery or one type of organ could also provide information that is applicable beyond that to other parts of the anatomy, other surgeries.
I also think it would be really helpful to tell the model what surgery is being performed, because that is a known piece of information and it is likely to improve the model's ability to understand what's going on.
Right, so without a doubt, and that's the goal of this as well. That falls within the software groups, and ideally, in an ideal world, would be like, let's load a procedure on this surgery is going to happen. There's going to be a laparoscopic cholecystectomy. Then all the weights goes towards to that anatomic region, those organs, those particular specific anatomies, and to build upon that. That's a great point you just made.
It's an important point that also almost every member of our group had voiced at the beginning. Remember, I mean, we had to hold them back. Mm-hmm. Everybody was inclined to kind of focus on procedure. Yeah. I felt more comfortable starting with procedure, and we had to kind of go back and say, well, yes, eventually we'll get there, but we need to kind of make sure we have everything already labeled before we go into specific procedure. But you tell us. I mean, if the comment was really good. It's outside of the context of knowing what procedure it is. It's tough. I can see the problem there.
Mm-hmm. Yeah, Pat. So that's a very good comment you just made, and that's going to be now to the phase 2. I will start wrapping things together, and I think probably an ideal thing would be to start getting a lot of people from tissues characteristics group with the software groups. Start doing some cross pollination right there. But if you already can tackle things like this, such as this image, that a machine can look at and say the only pretext is this: a surgery is occurring. What's likely happening here? And you're going to say, oh, it's going to be a colectomy. That's a really huge win right there. Then you start adding more of those, just saying, no, this is the procedure that's happening, and then goes to this point and say that which phase of the operation is this one. So yeah. So I think the goal of this working group has been achieved very nicely, which is to describe in a hierarchical way the tools, the tissue, and general anatomy. And then the goal from now is to start playing with them, performing actions on them within temporal modalities and go forward.
Well, you said it so elegantly, Oz, that we're all stunned by the elegance of that statement.
I cannot repeat that. Anyway, so
I hope we're recording this, right? We are recording this, right?
Oh, that's perfect. Yes. So I said that. It's awesome. Okay. God.
Anyway, the opening recording played in Houston.
Yeah. So Jillian, please send the segment to me for tomorrow morning and rehearse several times.
All right.
So anyway, nevertheless, I was going to say, because we're going over 1 hour from the call, I want to be respectful of everybody else's time. Like I said, for the other groups, this is an awesome chat. I'm going to be here as long as anybody wants to. You guys are welcome to. But I just want to ask Pat and Larry to give their closing remarks, and then we can discuss the next steps.
Yeah, I have nothing. Pat, why don't you just go ahead and close for us?
Well, I'm humbled because I think this is from what I gather, this is a good start to really have a lot of labels. But I think the challenge now becomes to, to focus on the next step. So, I mean, you said it very nicely, but I think I'm more of a pragmatic surgeon and focused on specific tasks, as you know. And so the more guidance we get for the next steps, the better. I mean, I want to come to the meeting prepared to, to start to tackle everything that was raised today and have a product we can deliver.
Fantastic.
So yeah, actually, on that point, I can actually
sorry, go ahead.
Pat, so thanks very much. This is really awesome, and there's a lot of points in here that I know certainly I haven't thought of, and so this is incredibly educational for me as well. So just to give everybody a sense of heads up, and I apologize to anybody who was on the other working group presentations that have to hear this again. So sort of from here, Amin Madani and I are going to be taking the slides and the reports from each of the different groups, and we're going to start collating to see what are elements that were consistent across each of the groups, where there seems to be some consensus already building, and then see where there are any areas of potential discrepancy. We'll also touch base with each of the working group leaders to see if there are particular points that the working group leaders thought need further clarification, either within the group itself or from the larger group as a whole. And this is all building toward developing a first round of a modified Delphi consensus that we'll send out hopefully about a week and a half before the Houston meeting, so that people can start to engage in the process of voting on which general concepts from each of the working groups they agree with, which they disagree with, and which they agree with but with qualifications. We're hoping that will inform some of the discussion that happens in Houston, and will provide a little bit of additional guidance to each of the working groups. So with that being said, I think one of the things that that this group can think about, that is the working group can think about, is are there areas of clarification that need to be made in the spreadsheet before potentially putting out to the group, to the bigger group of 50, 60 people, to vote on in terms of, how granular, how not granular. Rachel's point about tags versus semantic segmentation or instance segmentation. I think those types of ideas to coalesce on and say, as a working group, we think X, Y, Z, and then we can present those to the group at large, and that could be really helpful moving forward.
What is the time frame to present the spreadsheet to the group at large?
So the spreadsheet to the group at large, so there's going to be sort of two different ways that it'll sort of be presented. One is that we are going to try to send by, I guess we'll say by the 13th or so, Amin and I are going to try to send out a first round sort of Delphi voting. We still sort of have to go through this presentation and look at the others. I don't know that we'll necessarily share the spreadsheet with the group at large, because I think there's still going to need to be some tweaks, and the first round will focus more on broader concepts of annotation. So I think that the first time that this spreadsheet will be presented largely will be in Houston.
Yeah.
Or maybe just a day prior to, so people can start doing their homework before getting there.
Exactly. This might be some pre-reading ahead of Houston, so that people can come armed with comments.
Mm-hmm.
Yeah.
Okay. From today's conversations, I had a few notes that I would follow up with Pat and Larry and others, and I just wanted to understand the time frame.
Yeah. Who's speaking right now? Who is this? I'm sorry. Okay, Swaroop. Yeah, because I think there were some, for me at least, guys, there were some really important concepts, and the concept of hierarchy and abstraction. I think these concepts we need to integrate, and the concept of really labels versus tags that Rachel brought up, I think is really important. So I think if we can at least go back to the Excel sheet and reorganize it, keeping those in mind, and what will be sort of like first, second, third layer, and reorganize our sheet based on hierarchy, I think that will be really important. So we'll be reaching back to you guys to start to reorganize it accordingly.
Another suggestion would be or either, I don't know if Rachel could create also a Google Doc, like a Word document as well, so people can put their comments, versus putting an Excel spreadsheet as well.
Yeah, sure. I can create a document for that.
No, we already have a Google spreadsheet. So.
And I hate to say, but just based on the attendance, I mean, I think the core group that we have on the phone, plus Janie Pratt, I think, have been our heaviest contributors. So since we don't have a lot of time, I think we should just kind of rely on that core group to get prepared for the bigger meeting. No pressure.
No, Pat, I agree with your suggestion, and Jillian is keeping tab of that. We're going to follow up tomorrow with this core group of people working. Of course, we're going to see the others, but I mean, we're expecting the guys on this call to be providing the fundamental work. And again, there's only 3 more weeks and going to be there. It's going to be fantastic.
Right. So thank you everyone for coming on the call. I can't thank you enough, and then we'll be in touch.
Okay,
Thank you, Pat. Thank you, Larry. Thanks, everybody.
Goodbye.
Thank you. Good night. Thanks, Julian. Bye.
Thanks.